Hi, everyone. Welcome back to Clinicians Brief, the podcast, where we bring you the conversations behind all of our clinical content. I'm the host of this show, Dr. Alyssa Watson, and I am so excited for today's episode because we are going to be talking all about techniques and tips for performing abdominocentesis in our veterinary patients. Joining me for this conversation are two outstanding emergency and critical care specialists, both from the University of Florida, Dr. Odunayo and Dr. Wan Chu Hung. They're here today to kind of walk us through this procedure, which we know is a really essential diagnostic tool, but also oftentimes can be therapeutic. So whether or not your patient has a belly full of fluid that you need to drain or just a really small amount of fluid and you want some tips or tricks on how to get a good sample, they're going to be sharing some practical step-by-step guidance and some real-world insights from the ER. So welcome both to the show. I'm so glad you both are here. I'm going to give you just the opportunity to introduce yourself to the audience and tell us a little bit about your journey.
Sure. Hi, my name is Wan Chu Hong. I'm currently a clinical assistant professor at the University of Florida. I'm from Taiwan. I got my DVM degree there. After practicing for several years, I decided I really love emergency and critical care and want to become a specialist. So I came to the United States in 2017, and it has been a long journey. Eventually, I finished my residency at Auburn University and become boarded in 2023 and joined University of Florida till now. And yeah, it's nice to meet you all up in air.
It's so nice to see you again. You're one of our veteran podcast guests.
Thank you, Dr. Watson. It's good to see you too. My name is Desala Odunayo. Keeping up with the international flair, I grew up in Nigeria uh, and went to vet school at Oklahoma State, finished in 2005, and ultimately finished my residency in 2010 at the University of Missouri. And I worked at Auburn University, the University of Tennessee, and I have been in Florida since 2021.
All right. Bit of Auburn in there. I have another good friend that did his surgical residency at Auburn. So
Yeah,
very,
War
very good
Eagle.
school. Yeah, War Eagle. All right, well, let's jump into this because I have lots and lots of questions for you both today. So let's start out just with a little bit about the different types of abdominal effusion we see in veterinary patients. Can you kind of walk us through what are some of the most common causes for fluid buildup in the abdomen? And also, especially for practitioners like me, which ones might signal the need for really emergency intervention?
Yeah, that's a great question. I can start, and Juancho can fill in anything that I may have missed. I think, just like you said, Dr. Watson, it's a really common procedure that we not only do in the ER, but general practitioners along the different aspects of their job have many opportunities to see patients that come in that need abdominocentesis. Common reasons, and in terms of things being critical, first would be for the diagnosis of a septic effusion. Where an animal either has a ruptured GI tract that's now leaking and causing sepsis. Sometimes you'll see liver abscesses also cause sepsis, or animals who have had, bullets go through the abdominal cavity and then ultimately develop an inflammation and infection secondary to that. I think another common reason will be animals who come in with the hemoabdomen often secondary to a bleeding mass, although sometimes we can see that secondary to trauma and less commonly, but also possible, secondary to like rodenticide exposure or anaphylaxis, which we've been seeing that also as a more common cause of hemoabdomen. I would say both for patients with sepsis and patients with hemoabdomen, those patients often come in hemodynamically unstable. So those are the dogs and cats who look really terrible when they come into your practice and you're not really sure what's wrong with them. And in many cases, identifying that there is fluid in the abdominal cavity and then sampling it would be a quick way to make a diagnosis and try to, move forward with the care of that patient. Dr. Hong, was there anything else I missed out?
Yeah. Other, I would say probably less common, but we can still see will be like abdomen rupture of the anywhere in the urinary tract, most commonly urinary bladder, or sometime when the patient has some protein losing disease processes happening, for example, protein losing nephropathy, protein losing enteropathy, as the disease progress, or if the disease is not uh, managed, it's not stable under management, then sometimes you can see effusion building up. Those infusion usually tend to be more like low protein, like transudate. Or another case scenario I can think of will be patient with right-sided heart failure. They can also develop ascites that require interventions.
Yeah. Those are, you kind of just went through the main ones that I see, in practice there. When it comes to diagnosing, this is something, that has changed quite a bit over my career. When I first started practicing ultrasound, patient point of care ultrasound, in general practice was not as widely available and as widely used as it is today. There's some advantages and disadvantages, I feel like, when it comes to diagnosing abdominal effusion with each. Could you walk through that for us?
I can do this one, and Jessela can jump in if I miss anything. So I would say generally, in my experience, ultrasound is more sensitive to detect abdominal effusion, especially if the effusion amount is small compared to plain radiography. The key advantage of ultrasound, like I said, it's increased the sensitivity pretty greatly in detecting the effusion. And usually for these patients that presented with effusion, quite often they're unstable. So with the point of care ultrasound, you don't really have to move the patients to the X-ray room to get the X-ray done. And you also don't really need to restrain the patients a lot or kind of put them into different positions. For example, dorsal recumbency, um, which sometimes if the patient is really unstable, those restraint or positioning can decompensate the patient. So I think those are the key advantage of ultrasound. The downsides, obviously, ultrasound can be, the machine itself can be quite expensive to purchase and to maintain. And also clinician experience does affect the findings and results. So that's about the ultrasound. As for the radiograph, it's pretty readily available in many clinics. And to me, one of the key advantage of radiograph is that with one shot, you can get a more global picture of the abdomen and potentially to identify the cause of the abdominal effusion. For example, if you see a big mass on the spleen, along with the effusion, then there's a high suspicion it's probably hemoabdomen. Or if you see free gas in the abdomen along with the effusion, then that probably indicates this patient has septic peritonitis, probably need to explore, probably to find out where the rupture is. So that is the key advantage of the radiograph to me. The downside, like I kind of already mentioned, the patient need to be restrained and need to be positioned, which can sometimes cause some hemodynamic instability.
Yeah, I agree with everything you said, Wanju. I was just telling my students this in rounds just before I came up. We weren't talking about this topic, but we were talking out about how yesterday was. my 20th year since I graduated from vet school, which officially makes me old, and that's okay. But I say that to say that I practiced for a few years without ultrasound at the beginning of my career, during emergency, and I would say the life with ultrasound is infinitely better. Despite the advantages of X-rays, it is just really nice to be able to see a patient who is, especially the ones who are unstable, you're not sure what's wrong with it. You're essentially going on a hunt. You can do that quickly and inexpensively. I think we charge about maybe 50 or 75
50.
dollars for a point of care ultrasound here, and honestly, some practices charge less. But you're able to get that answer for that client really quickly before you invest a lot of money on X-rays, because sometimes the client might choose not to proceed with, more diagnostics, or you have a more focused plan of what you need to do based on what you find on ultrasound.
So I'd have to say, when it comes to my comfort level with doing this procedure, I'm certainly a little bit more comfortable with abdominocentesis than I am with like thoracocentesis. That one I like to have my ultrasound a little bit more. Are there any real clinical situations in which abdominocentesis is truly contraindicated? And how often do we see serious complications when performing this procedure?
I would say not very often. I'm kind of thinking really fast, and I don't actually can think of a situation that comes to mind. I would say that it's pretty safe.
Yeah, I would say the one type of case scenario that will be very cautious about performing abdominocentesis, probably when the patient has really clinical clotting dysfunction, either really severe coagulopathy or like severe thrombocytopenia. And usually for those cases, we will make the decision very carefully whether or not we should perform this procedure. If we're going to perform, usually we use smaller gauge of needle. And yeah, in my experience, I don't recall I have any case that's kind of turned into like a really challenging situation to manage after the procedure, but I'm knocking on wood.
Kind of building on that, what considerations do you use in order to determine whether or not you want to sedate a patient for abdominocentesis? And are there any sedatives or protocols that you would avoid in a patient that has particularly like a large volume of effusion, or you suspect maybe something like that cardiac patient, that has a belly full of fluid secondary to their heart failure?
Um, so for me, I love sedations. I pretty much always provide some sort of sedation for my patient when I perform abdominocentesis, unless, like you mentioned, in some patient, if they're has severe heart disease, they are hemodynamically unstable, then I would avoid sedation. So to me, sedation for the sedation protocol I use, I usually incorporate opioid as part of my sedation plan. Either it's like butorphanol, or if some patient they already are painful with their underlying disease processes, then I may choose full mu agonists such as methadone or hydromorphone. And if the patient has large amount of effusion that require them to stay on the table for longer, I may add a little bit of dexmedetomidine. Um, I like it because it's reversible and it's generally pretty safe. And one more most important thing I would like to highlight is the local anesthetic. I personally had some experience myself using local anesthetic, and I really love it. I think it really provide really good pain control, and which allows to perform a lot of procedure and lower the general dose of sedations. So for those really critical patients, if I'm not gonna use sedation, I will still use give some local anesthetic to kind of help with the procedure.
Yeah, I would say that I agree with that. I do find that for most of my critical patients, they are less inclined to be bothered by the abdominocentesis, especially when doing a diagnostic synthesis. So I want to see if this is a septic abdomen or a hemoabdomen, and uh, especially the patients who are hemodynamically stable, they honestly just don't really care, and they're just laying there. And in more cases than not, in those cases, I just do it without sedation. I would say the group of patients where sedation is probably more of a priority in my experience is those dogs who have a lot of ascites where you want to do a therapeutic synthesis. You're taking 2 liters of fluid out of the abdomen. They may be really anxious, like those cardiac patients where it's a dog with DCM. And I love butorphanol because it has like really minimal hemodynamic effect. So it's not really going to affect the cardiac output significantly if it's a dog with DCM, for instance, and still provide enough of a effect to just mellow the animal out. They very infrequently have to be like not moving for the abdominocentesis. You just don't really want them to jump off the table when you put in a catheter. And I like butorphanol, I would say, for those circumstances.
That's great. Thank you. And we are definitely going to talk a little bit more about those, large volume therapeutic abdominocentesis later in the episode. But just before we get to that, I do kind of want to circle back. Like we said, you said you love your ultrasound,
I do.
but there's still a lot of practices that don't have ultrasound available. So let's take just a few minutes and talk about that blind approach to abdominocentesis, and how you approach things like patient positioning and how that influences, our needle placement when we're doing that procedure.
Sure. And I can say, especially as somebody who has kind of done them blind pre-ultrasound, it is definitely possible, very doable. One should not be anxious because you don't have an ultrasound. I find it easier to have them in lateral recumbency. And I would say in those situations, that diagnosis is mostly made based on radiographs. I presume that those practitioners have taken an x-ray or the animal has an obvious like fluid wave and abdominal distension, so they've made the diagnosis. So I usually will again put them in lateral recumbency, give them a little bit of butorphanol or whatever, depending on how um, calm that patient is. You want to shave, so around the umbilical area, give or take, if you don't have an ultrasound to kind of guide you where you need to go. Do your surgical preparation, and then, I use needles. I, in general, don't use anything bigger than a 22 gauge needle, especially if you're going in blindly in the abdominal cavity. And then for most patients, I just use a 1 inch long hypodermic needle. I find that that's long enough for even the average dog. Although if you had a small dog or a cat and you had the shorter 3/4 length 22 gauge, that would also work perfectly for the small dog or cat. And then the key is to attach that needle to a syringe is probably best, especially for your first diagnostic sample. And the nice thing about dogs and cats, I think the one advantage we small animal practitioners have over like the equine practitioners is the needle is generally it's going to push your intestines away if you have any bowel in the way. It is really unlikely. I always say, even though I am also not a surgeon, but I always say I remember doing a few enterotomies. You're going to have to hold onto the intestines and give it some tension to be able to cut through it, right? And it's really hard to get that needle unless you had that bowel that was just really distended and full of fluid. It's really I don't want to say impossible, but very unlikely that that needle is going to go through. So it's just going to push it out of the way so that you can get your needle all the way. I usually go all the way to the hub and then you can aspirate back on your syringe. I think in the paper, we also talk about the 4 quadrant technique. If you're doing it blind, if you have like a very small amount of fluid, that you just cannot sample. And I have actually used the 4 quadrant technique, even with ultrasound, identifying a small amount of fluid that you just can't get. I find that to be a little bit more sensitive in retrieving fluid, where you identify again around the umbilicus, just the four quadrants. So cranial, caudal, dorsal, and ventral, and you shave and prep, and you insert your needles like all the way into the hob, with all four needles in at the same time. Potentially, if you don't get any fluid back, have all four in, and then aspirate back gently and remove the needles. Want you
Yeah, that
any
was
other?
Well, that was really interesting to me. I had not heard about that four quadrant technique before. And so I encourage everybody at home, go ahead and check out the article because there's a wonderful picture of exactly what you're describing there. But just like you said, it's, right around the umbilicus. Go ahead, Dr. Hong. I'm sorry.
Oh, I just want to say I agree with Tesla. So I think one of the most common fear that general practitioners have is if you do blindly, what if you poke something you're not supposed to? But really, my experience, like if you advance your needle like steady, like it's I haven't had one that really lacerate any organ. Obviously, we don't recommend you to just kind of push really fast or stab it, but yeah, most of the time, there are some capsules outside most of the organs that the needle should push those organs away instead of just penetrate it.
And sometimes we do go into the wrong place. I mean, there are times where we go into the spleen and you get blood back because you have perforated gone into the spleen. And thankfully, the spleen is very forgiving and it gets a little upset because it bleeds and then in general it stops bleeding unless the animal has a coagulopathy or reasons like that. And what I usually say is if you get blood back and you're not sure if this is because I went into spleen or liver, which generally, if you're going in the area of the umbilicus, unless the animal has splenomegaly, it's probably less likely that that happens. But you just want to look and make sure that blood is not freely clotting. If there is a blood clot in your syringe or you put it in a red tub tube, then that indicates active hemorrhage that has probably happened because that needle went into a solid organ, and you want to be careful about how you interpret the results based on that.
Realistically, how many team members does it take to perform this procedure?
Um, So I would say probably two in general. So usually one person will be the one need to stay sterile, need to be the one that performing the procedure, while the other person needs to monitor the patient, and try to open those sterile supplies or try to kind of catch the effusions. Um, yeah, so I would say most of the under most situation, if the patient is sedated or if they can be just laying there for a little while, not being too stressed about the procedure, usually two people should be should be enough.
To be sufficient.
If you've noticed your dog having difficulty moving, jumping, or playing, it could be a sign of osteoarthritis pain, or OA pain. OA pain is a chronic condition that impacts how your dog moves and feels. Do you think your dog is showing signs of OA pain? Know that treatment options are available. Ask your vet about what they can do to help control your dog's OA pain. Tap Learn More for details.
So, Desla, before the break, you talked about, if you do the procedure and you encounter blood, how we can kind of differentiate iatrogenic hemorrhage between true hemoabdomen. One of the things that, I always come back around to whenever I do have that hemoabdomen and my patient that is potentially unstable or in a crisis situation is performing an auto transfusion. Is that something that you could just kind of discuss when that might be appropriate?
Yeah, that's a great question. And I love your dog in the background. Um, but yes, auto transfusions are also, I think, a fun emergency intervention to perform. In cases where we're going to be doing that, it would be animals who are bleeding into the abdominal cavity and sometimes into the thorax, but we'll kind of focus on the abdomen today since we're talking about abdominocentesis. And the main indications will be the patient who comes in with signs of shock secondary to that hemorrhage. So, because sometimes we will have some bleeding into the abdominal cavity and the patient's stable, but it would be that patient who is like laterally recumbent, tachycardic, with pulses hypotensive, where they're essentially telling you that I need more hemoglobin to carry oxygen because I've lost quite a lot of it in my abdomen. The best, I would think, candidates for those would be patients who have trauma, where there's maybe a splenic laceration or liver laceration and they bleed into the abdominal cavity. Potentially animals with the coagulopathy, the only caveat to that is you don't really want them to bleed more by inserting a needle into the abdominal cavity. So that kind of has to be a game time decision that you would make as a veterinarian as to essentially what's worse. If the patient is literally about to die, then I would have no concerns doing the synthesis. And then in most situations, you may not have blood available on hand in practice. Because if you do, I think it's best to go ahead and give whatever stored blood products you have, because you can get that done faster in an unstable patient. But in situations where you don't have it available or that patient has used up your blood resources because that patient's just having a lot of bleeding, then auto transfusion will be fantastic. And we would do it. The other example or indication that tends to maybe be a little controversial will be animals who are bleeding because of a mass. So presumably a hemoabdomen from hemangiosarcoma. And the controversy is potentially transfusing malignant cells that's collected from the abdominal infusion, putting that IV and potentially disseminating that cancer is where people kind of sometimes have mixed opinions as to whether they would auto transfuse an animal with a bleeding mass. But the steps are pretty similar to collecting like a large volume abdominocentesis that was described in the paper. So ideally, you would want a large bore catheter so that you can get that blood out relatively quickly because you're trying to give it back to the patient quickly. In this instance, you want to ensure that it is being collected sterilely into, a sterile bag, and then so you can use a syringe and attach it to, your catheter and draw it out and collect it into a bag. Or you can, sometimes I have just collected it straight into syringes and given it to the patient from the syringe. But I think the main thing is you want to ensure that there is a filter connected to that syringe so that you're not giving clots back to the patient. There is also different opinion about the use of anticoagulants in that situation. Some people believe that when a patient bleeds into the abdominal cavity, the clotting factors are used up, so you shouldn't really see that blood clot when you collect it into a syringe or a bag. So some people don't use anticoagulants. Some people will use something like CPDA, which is what's used for blood product, or if you're out in general practice, you can actually use heparin. It's like a 1:9 ratio, give or take. So I think that's just kind of depends on you as the veterinarian as to whether you want to add anticoagulant to the blood that's collected from the abdominal cavity. But I would say the steps are pretty similar to doing a large volume abdominocentesis, and then you're just giving that back to the patient.
Yeah, and I think one more thing I can think of on top of what Tesla just described is when you perform auto transfusion, it's important to try to maintain the whole system as a closed system as much as possible to just kind of lower the risk of contaminations. So which means usually you try to hook everything up, the needle, the extension set, through a stopcock or the bag and the filter before you actually start pulling the effusion from the patient and give it back to the patient.
That's a really good pearl. Let's talk a little bit about diagnostic peritoneal lavage. This is another thing that the article walks through really beautifully, walks through the steps of this. For clinicians that are less familiar with this, with this procedure, can you explain why you would choose diagnostic peritoneal lavage versus a standard abdominocentesis?
So I would choose diagnostic peritoneal lavage over standard abdominocentesis when the result from the standard abdominocentesis is negative, or if the effusion based on the point of care ultrasound, we know effusion is so small, or there's no good fluid pockets for us to sample. But if we determine getting those effusion will help tremendously in making the diagnosis or guiding the treatment, then I will consider diagnostic peritoneal lavage.
So it sounds like this is when we have a really, really small amount of fluid that we need to, that we really feel like would help, like you said, our diagnostic, our diagnosis and our treatment plan. How do you perform this procedure?
Sure. So basically the prepping steps is similar to the standard abdominocentesis. Usually we will empty the bladder since that's the area where we kind of gonna insert our catheter in. So everything's prepped sterilely. We insert the catheter about like 1 inch caudal to the umbilicus and basically pointed a little bit toward the bladder, but not like basically like 45-degree angle caudally, if that makes sense.
Mhm.
And we usually will infuse some warm normal saline. Usually, I think the volume is around 20 ml per kg. Infuse it slowly into abdomen and then clamp it. And you don't remove the catheter or the needle. You keep the catheter in the location. You clamp it and you kind of just roll the patient or massage the belly a little bit, give it a good shake, gentle shake, and then you unlock it. Then you either let the fluid drain out from the catheter, or sometimes you may have to try to pull a little bit from the syringe to collect the effusions.
And I would say that that is definitely one that sedation might be helpful depending on what the patient looks like, since you're going to be doing a few manipulation with the catheter still in place.
Sure. Yeah. And might be in place a little bit longer too. So
Mhm.
let's go the other way. Let's talk about those large effusions. So, well, the opposite. What conditions, are we using? Well, we've talked a little bit about what conditions we want to use those therapeutic abdominocentesis for. My real question is, I have over the years heard a lot of disagreement about how much fluid you can take off of an abdomen safely. So what hemodynamic changes should clinicians be watching for if we're removing a very large volume, like you said, 1 to 2 liters off of an animal's belly?
Yeah, and that is that's a great question, and that is, I guess, a controversial state. Well, that is an opinion that people have varying views on. I'd say personally, I have not really had any sort of restrictions on volume. And I have talked to a few cardiologists about that because they tend to be the ones who also in a situation where they're taking large volumes for the animals with right-sided heart failure. And, none of them so far have told me that they have significant concerns. But certainly, I would say things that might indicate shock. The reason why it's unlikely to be the case is that fluid is not part of your intravascular volume. So you shouldn't really see any significant detriment to taking it out because it's essentially in a third space. It's just like with pleural effusion, when we have that, we're not really as concerned about removing that when an animal comes in with respiratory difficulty. But I would look for, and I think that's true for any animal that's having any procedure, because patients with abdominal effusion very often will have something else going on. So, either because they're septic or they're bleeding. So I think it is important that all patients are monitored during the procedure, but and also after. So looking for signs that would indicate shock of pulse perfusion, which would be, my favorite will be changes in the heart rate. So we would tend to see tachycardia, except cats tend to be bradycardic. So a cat with a heart rate of less than 160 would be a little bit concerning for me. Pill mucous membrane, weak pulses, hypertension, maybe cold extremities. Those would all be indications that that animal needs to be attended to.
Cats always have to do the opposite of
They
everybody else.
they keep us on our toes.
Yeah.
After you have got your sample, what tubes do we need to have ready? What are our go-to tubes for collecting these samples? What tests do we need to run so that we can classify this effusion and really get that diagnostic answer that we've been looking for?
Yeah. So definitely purple top, which is the tube that coated with EDTA, and the red top, which is the one doesn't have any anticoagulants. Purple top is usually for cytology. They preserve the cells much better than other tubes, and the red top. We use that for culture, or like what Desola mentioned earlier. Sometimes we are not sure if this hemorrhagic effusion is from iatrogenic or a true pathologic hemoabdomen, then we can use that to observe. And as for the diagnostic test, so always PCV total solid cytology. And the other diagnostic, to be honest, if we really want to be pick very critically to save clients money, then it depends on the history and the physical exam finding. For example, how suspicious you are that this patient has uroabdomen or something else. But in general, if you run a whole blood gas on the effusion, that should give you pretty much the majority of the information we need. For example, the potassium and the creatinine can help us make the diagnosis of your abdomen. The glucose and lactates of the effusion, you can compare that with the peripheral blood to help you support the diagnosis of septic effusions. But for septic effusion, the way to 100% confirm that is through the cytology, the culture.
Yeah, and I would just also add that for those practices that don't have blood gases, it's essentially just using the same machine you use it for your chemistry. So for those patients, you've probably already done a chemistry on their blood, and that effusion you collected can go in pretty much all machines. Obviously, check with your manufacturer and make sure it's safe. The main thing is you just want to ensure that there's no solid material going through. So we would use a clot catcher before putting it in a blood gas machine, but your regular chemistry machine would also work.
I had a question about timing of the sample collection. This might seem funny, but I have actually done an abdominocentesis, gotten all my fluid, and all of a sudden gone, oh my gosh, I forgot to get samples. So does it matter? Is it best to collect your samples right at the beginning of your centesis, or should it be, we used to talk about a midstream urine collection, right in the middle? Does that matter at all?
I don't know that it matters, but I would say it's best to go early. So we usually save the samples we want within the first collection. And I think that way, just doing it that way just makes it less likely that you forget because you have those samples saved. But I think the other place where it's probably helpful or important is when you're not sure if it's hemorrhagic and you're not sure if this is going to clot. So instead of removing, 300 mils of blood and being like, oops, that all just came from the spleen, you would know within the first, 5 mils because you've kind of saved that sample, that this is probably more from a blood vessel. But otherwise, I don't think it matters. I just think it's better to get into the habit of saving it first, because then you're less likely to forget.
Yep. Then you're less likely to end up with the oops like I did.
We still sometimes get the oops, but I think usually, thanks to technicians, they keep us in line. So I think if you left it up to us as the doctors, we're probably unlikely to remember, but techs, they collect it and they usually get it first.
Yeah. Now, how long are you monitoring these patients after abdominocentesis? What are kind of your parameters that you're marking off so that you consider them stable and can let them go home?
That's a good question. I think that depends on the patient's underlying disease. For example, if it's a patient with septic effusion, then obviously they probably require pretty intensive monitoring until they go to surgery. Hemoabdomen, similar, they need pretty intensive monitoring, and main goal is to see if they refuse. If the bleeding continues, that will probably tell us the patient need more aggressive intervention to stop the bleeding. If it's like low protein transudate or right-sided heart failure, usually after we finish the abdominocentesis, they usually seems much more comfortable. Those one I tend to be more comfortable just sending home within a couple of hours if the sedation doesn't seem to affect them that much if they had sedations. The other scenario I can think of is if there's a whoop situation, you actually lacerate something and cause a little bit of bleeding. Those patients, sometimes we also will monitor a little bit more closely in the first probably 6 hours, 6 to 12 hours. Sometimes we'll do repeat POCUS just to see if there's any large effusion reaccumulate.
And then finally, when should a general practitioner like myself consider referring a patient for more advanced diagnostics or maybe some of these procedures beyond what I can do in the clinic with just a blind abdominocentesis?
That's a great question. So I would say that it depends, obviously, on what you're comfortable with, what resources you have available at your practice. So some practitioners will be really comfortable managing a dog with right-sided heart failure, post abdominocentesis, and just send it home on some dobutamine and have them follow up with a cardiologist. And some practitioners would be, well, I'm not really sure that this is what the diagnosis is. I think you need to go get more answers. So I think certainly if you do the abdominocentesis and the answer is not clear, and sometimes it's not immediately clear, and that happens sometimes, so more often than not, with dogs with bowel peritonitis. So you're like, oh, I'm not really sure what this is. I'm not sure what I'm seeing. I think that warrants referral. But also, if it is something you've been able to diagnose, the dog comes in within like 5 minutes, you have diagnosed the septic abdomen, incredible. But I don't have the resources to take care of this patient after surgery, even if I could do the surgery, or it's a chemoabdomen, then I think that would also be good reason for referral.
And yeah, I would say if you're not sure, just communicate with the referring facility, and I believe most of the specialist or facility, they're happy to kind of chat and discuss to see what's the best for the patients.
All right, well, that wraps up our discussion on abdominocentesis, and that will bring us to the end of our podcast. And normally this is when we would play rapid fire, which is our would you rather game. But since there's two guests, we get to play agree or disagree. So before the podcast, I had you both take a sheet of white paper and write agree on one side and disagree on the other side, or 2 pieces of paper is fine. And what I'm going to do now is just read off a statement, and you just tell me whether or not you agree or disagree, and then we get to see if we all match. All right?
Okay.
Right.
Would you both like to play?
Yes.
Sure.
All right, here we go. All right, so first one. I get way more anxious about my own pet's wellness than any patient's. Like my own pet's wellness exam. Yeah. We've got one agree and Dessel, I can't.
Disagree.
It's agree. Yeah. Disagree. You're like, nah, my animal's gonna be fine.
I love my pets, but I am a lot more anxious about my patients. I don't know why.
That's good. That's great.
I'm already told multiple times that I'm a helicopter pet owner, so.
We have lots of those that I work with as well, so everything's good. Okay, the correct abbreviation for subcutaneous is SQ, not SC. Oh, they're not the same again. We have one disagree and one agree again. I have to say I'm an SQ person, so.
Is there a correct answer or both actually?
No, there's no correct answers to any of these things.
Well, I honestly used to do SQ until I started writing for Clinician's Brief, and all my SQs got corrected
changed
to SC. So I am SC now.
I do think we have a style guide that SC over at Clinician's Brief, but I tend to disregard that in my clinical practice sometimes. Yeah. Don't tell our editors.
No, not telling.
Okay, next one. I secretly hate it when disease names like HGE or LARPAR get changed, even if the new names happen to be more accurate than the old names. Agree. We all three agree. Thank you. Okay, last one. If a stranger at a party asks what I do, I pretend to have a different job so I don't have to answer any pet questions. Disagree. Everybody loves to help strangers at parties. Well, I love that.
I'm just not good at keeping up with making up stories and forgetting what I told them. So that's the only reason I don't. I would much rather not talk about my job.
Same for me. Yeah, I don't remember about this thing I make up. So, and I just make things worse.
Yeah, I'm a terrible liar and have a horrible poker face as well. And I have a really good friend who they went on a cruise and they were seated, with a bunch of other people. And she had decided she was not going to be a veterinarian for the length of this cruise and told everybody she was an accountant. And everybody else at the table actually was accountants.
Oh no.
So I'm like, that would happen to me because that's just my luck. All right, that was it. You guys did great. Thank you so much for coming on the show, sharing all your tips and tricks with us. I know I learned a lot. I'm sure our listeners did as well. And for those of you at home, thank you so much for joining us again for Clinicians Brief the podcast, and we hope to see you next time.
Thank you for having us.
Thank you for inviting us.
Thank you for listening to Clinicians Brief the podcast. If you enjoyed today's episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcasts on our website at cliniciansbrief.com/podcasts. Or drop us a line at podcasts@instinct.vet. Clinicians Brief the podcast is an Instinct Science production, produced by Alexis Ussery and hosted by Alyssa Watson.